All right.
Got 2 attendees right now. We're gonna wait a couple minutes, folks, just for let some more people get in before we get started. Give it a couple more minutes, Dr. Comisar, before we get started
Sure.
here.
No problem.
All right, thank you for joining us for our educational webinar, Knee Injuries in Sports. Tonight's speaker will be Dr. Rodney Comisar, orthopedic surgeon at OrthoNeuro. Dr. Comisar is a board-certified, fellowship-trained orthopedic surgeon who specializes in sports medicine-related injuries. He has a subspecialty certification in sports medicine. Dr. Comisar offers a full spectrum of sports medicine surgery, including arthroscopy and minimally invasive procedures. Dr. Comisar's special areas of interest include ACL reconstruction, multiligamentous knee injuries and dislocations, shoulder instability and dislocations, rotator cuff injuries and tears, patellar instability and dislocations, proximal hamstring ruptures, biceps and triceps injuries, and shoulder arthritis, including total shoulder replacement and reverse shoulder replacement. Dr. Comisar will answer questions following his presentation. Please type your questions into the Q&A below at the bottom of your screen. And without further ado, Dr. Comisar, welcome.
Thank you. Let me see if I can share my screen here. So we need this one. Is that looking okay? Can everybody see that?
Yep, looks great.
Great. Well, again, I'm Rod Comisar. I'm an orthopedic surgeon at OrthoNeuro. I specialize in sports medicine, which is treatment of the primarily problems of the knee and the shoulder. I'm going to talk about sports-related knee injuries. If you have any questions or you can't hear me, let us know and we can kind of try to make some adjustments. I apologize for my background. We had this kind of cool green screen like Jeff has, and we played around with it, but I turned up looking like Blue Man Group, and you could still see my background. So we went with the messy office. So hopefully that will not be a distraction. So without further ado, I'm going to talk about sports-related knee injuries. Let me see how I advance the slides here. There we go. I'm going to start off first with some simple definitions just to kind of clarify what people hear when injuries are described. We talk about sprains. Sprains are typically injuries that occur to a joint and or a ligament or both, because the ligaments kind of support the bony joint, whereas a strain is an injury that involves muscle and or tendon. Contusions is a blow to like the thigh or the knee, either the soft tissues or in some cases the bone. We can certainly see bruises in the soft tissues like a thigh bruise, but also—
Dr. Comisar, one second.
Yeah.
Apparently we're having a little bit of issues seeing the shared screen. Can you unshare it and then share it again and see if it pops up?
Yeah, sure.
Sorry about that.
This one, right? You want to stop the share, you said?
Yep, there you go.
So it's off, and then I'm going back to it, shared screen. It would be that. Is that any better?
I can see it. Let's make sure. Okay, there we go. Good, perfect.
Is that better? I'm sorry.
Yes.
So talking
No,
about—
I think it was a setting. I think it was a setting on my end, so I think we're good.
So talking about contusions, kind of a blow to the soft tissues of the bone, and we can see what we term bone bruises sometimes by MRI. So types of sports-related knee conditions, they run the gamut from traumatic injuries that we see on the sideline that occur during an event or sometimes later in the office, and we're going to kind of focus primarily on those problems, but also overuse problems that are just more a result of kind of time and wear and tear, and often the type of sport, be it track, from running, swimming in the shoulder, baseball, etc. And those are a few things we're going to kind of touch on at the end if time permits, and certainly I'm happy to answer questions about those areas. I think it helps when you're talking about knee injuries to understand the knee anatomy. The knee anatomy, the picture on the left is a right knee. We can kind of see the kneecap in the middle, and the quad muscles are 4 parts of this quad. That's where the quad comes from, where they all coalesce into what's called the quad tendon, and then down to the patellar tendon. And the quad muscles are critical with respect to knee function. And we really will hear a lot of emphasis on that when we're rehabbing either injuries that don't need surgery, but certainly after surgery, that's a critical part of the rehab process. The center picture shows a right knee that's flexed with the kind of the kneecap taken out of the picture and the quad. We're seeing what's called the distal femur or the thigh bone. And this area in the middle here is called the trochlea. That's where the kneecap tracks or glides. This surface here is the articular cartilage. Also, there's some seen on the lower leg here. It shows the 2 ligaments in the middle of the knee, the ACL and PCL, as well as on the outside, the medial collateral ligament and the lateral collateral ligament that help support the bones. Lastly, the menisci are like little washers or shock absorbers. They're a different type of cartilage that we can see here. And then on the far right is a cross section looking at the tibia from the top, but we can kind of see the medial and lateral meniscus. And the thing that's probably most relevant to this discussion is just you can see how much more the lateral meniscus covers up the cartilage, the lateral tibial plateau, compared to how much more space is available. And there's less coverage certainly by the medial meniscus. So knee injuries. Joint sprains are super common in sports of all types. The knee is one of the most commonly affected when you're looking at all comers with respect to joint injuries. It seems that statistics reflect 50% involve individuals between 20 and 29 years old. Roughly 2/3 of those seem to be involve males as opposed to females. Now, male injuries tend to be more contact in nature, whereas female injuries are often more non-contact, just twisting, landing from a jump, etc. So the acute knee evaluation, whether we're on the field and we kind of saw what happened, or we're in the office, we're going to try to determine, hey, what happened if we didn't see it? You know, did you plant? Did you get hit? Did you feel a pop? Did your knee give out or buckle on you? Were you able to keep playing? Could you walk at the time? Depending on circumstances, whether we're at the sideline or we're seeing them later in the office. Also, has this ever happened before? Have you had any treatment thus far? Any old surgeries? Is this a recurring thing? And then from there, we focus on a comprehensive exam. Certainly, if we're on the sideline or on the ice, we have to do a relatively cursory, quick exam to make sure the patient's stable, try to get them off the field or to the sideline or in the office where we can do a more detailed evaluation to kind of hone in on what we think the problem is. From there, imaging or x-rays, that's kind of the gold standard with an acute injury. Certainly on the sideline, we don't have that luxury, except in rare cases where certain stadiums have imaging capability. But in the office, in the emergency room setting, we're generally getting x-rays. And then also in many cases, MRIs, which you can talk about the indications for these things. So x-rays, when do we get them? Certainly it's easy to order one in a traumatic setting, something violent happened, kind of a collision injury. Certainly if the patient can't walk, if they couldn't weight bear on the scene or later in the office, if they can't take a couple steps, that seems to be an accepted criteria. There's some rules that we use in the emergency room setting for ankle sprains, and we've kind of applied them similarly to knee injuries. So to avoid unnecessary x-rays, but take x-rays when they're needed. Certainly if the patient can't bend their knee past 90 degrees, it's a reasonable indication to get x-rays. If they can't lift their leg up off the table, if older athletes who may be more likely to get a fracture or bone injury, or they may have some pre-existing problem that we want to further identify. And lastly, pediatric age athletes with open growth plates are vulnerable to different types of injuries than the rest of us will get as adults. And then lastly, when in doubt, no one's going to fault you for getting x-rays. How about an MRI? Everybody thinks they need an MRI. Professional athletes get them for all kinds of muscle strains that seem relatively benign. But, for the layperson, a good rule of thumb is if you have a traumatic injury and you have a large effusion, meaning lots of swelling in the knee, the joint will kind of balloon up and you can kind of see it's retaining some fluid, which is not normal. That's an appropriate indication. Certainly if the knee is grossly unstable, meaning when you examine it comparing to the other one, it's moving in ways side to side or front to back that the other doesn't, that's also an appropriate indication for an MRI. If the patient can't quite get their knee all the way straight, sometimes there's something blocking it as opposed to just pain causing it. That can be an indication to look for a torn cartilage or something loose in the knee. And lastly, an inability to lift the leg off the table or perform a straight leg raise. That means that's concern about everything being connected kind of above and below the patella or kneecap. And if the exam doesn't quite fit what you saw happen or what you heard happen and then what you find on the examination table, that's another instance for MRIs. So diagnoses, there's a multitude from the generic contusion we talked about, meniscal tears, ligament injuries, patellar dislocations. Those are kind of the areas we're going to focus on tonight, but certainly other fractures can happen, tendon injuries like we briefly alluded to with the quad and patellar tendon, and then injuries to the joint surface itself can happen. So initial goals or treatment for knee injuries across the board, we want to kind of minimize swelling, get the knee moving as best possible unless it's just fractured or grossly unstable. Try to get the muscles working of the quadriceps, like we talked about, that's so important for knee function. And lastly, improve gait. So if the patient's hobbling or can't walk, we want to get them on crutches or a cane or a walker or something to kind of assist them, not forever, but temporarily to kind of rest the knee in a sense. And how do we do that? We talked about crutches. If the knee is grossly unstable, it dislocated, there's a fracture, we're looking at brace options, less commonly casts. And then just things to control swelling, icing, elevating, compression or like a compression wrap, and then anti-inflammatory. So those will be kind of some recurring themes you're going to hear. The other point to be made is you don't always need to go to the emergency room or urgent care after such an injury. Many of these things can be addressed next day in the office. We certainly like to offer next day or sometimes same day availability, depending when the patient calls. We also have a great setup with an orthopedic urgent care where you get a specialist evaluation for kind of office level charges instead of paying ER or urgent care prices. So meniscal functions. The meniscus is like a washer or shock absorber. It kind of helps share the load, so it protects the other cartilage on the end of the joint. It helps stabilize the knee. They're secondary stabilizers, so they don't work like the ligaments, but they kind of provide some backup support. And lastly, they help lubricate the joint. There's a fluid called synovial fluid that kind of lubricates the whole joint, and the menisci are helpful in distributing that fluid throughout the articulation to kind of keep things moving smoothly. The meniscus can tear in a variety of patterns. One thing to remember, most of the blood supply comes way out at the edge or what we call the periphery. Most tears happen more towards the middle. Part of the reason they tear is because the blood supply is not as good. It also lowers the ability for these things to heal. So here's an example of an oblique tear, like kind of a flap that's loose inside the knee in the medial compartment. And this can be, or lateral compartment rather, this can be problematic, painful, and something that we typically would want to treat surgically. Similarly, on the bottom right here, this is more in that vertical or longitudinal category. This is what we term a bucket handle, where the tear can actually propagate farther enough around that the whole meniscus can kind of flip over like a bucket handle and get lodged in the middle of the knee. That's the kind of thing that can lock the knee where you can't straighten it. It's also, there's a little more sense of urgency because these tears are big. They involve a huge part of the meniscus in many cases. And they also can be salvaged in many instances where they can be kind of flipped back and repaired because they are kind of closer to that peripheral blood supply, whereas the majority of meniscus tears are not. So how do they present? Sometimes a twist, turn, squat, may feel a pop, but not always. They get some subtle swelling, but it can be inconsistent. The things we want to know, hey, is the knee popping, locking up on you, catching? Does it keep you from getting your knee straight? How about your gait? Can you walk? Could you keep playing at the time, or did you have to stop? Sometimes these injuries can be a little more subtle, so you can play through them. Does the pain localize? Is it on the inside or the outside? Because meniscal tears tend to localize from a pain standpoint, specifically if you like hyperflex your knee, hyperextend your knee, or twist. Whereas pain that's diffuse tends to be less obviously consistent with a meniscus problem. Here's an example of a meniscal tear on MRI. So here's the femur and the lower leg. The gray is the articular cartilage on the end of the joint, and these little triangles are the menisci. So we see this kind of a lateral or sagittal view of the knee. This is the anterior horn of the meniscus, the black triangle. It should be solid black in the back, but you can see this kind of white line through it, and that's what a meniscus tear looks like on an MRI. In this case, a medial meniscus tear. So how do we treat them? We just talked about symptomatically. Get that pain and swelling down. Can the patient walk it off? Can they run? Can they cut? Then maybe they can play. If they're limping, hobbling, we'll put them on crutches, kind of ice them down and reassess the situation. So this can be all over the place. If the patient has continued symptoms of pain, swelling, locking, giving out, can't get my knee straight in those rare cases, then those tend to be more surgical problems. But there's, we don't think the meniscus necessarily heals, but with supportive treatment, with what we talked about, the ice and the anti-inflammatory, sometimes some strengthening through a trainer or therapist, and occasionally a brace, they may be able to kind of press on and finish their season and move forward with their activity. The goals of meniscus surgery are to preserve as much of that meniscus as possible because it doesn't grow back. Historically, they used to take them and throw them in the pan, get rid of them when they were torn, and they realized that led to catastrophic progressive osteoarthritis of the knee. So we know that's not a good move. We certainly try to repair these. So here's an example of more of a peripheral tear on the bottom left, and then the center from the left, I guess. This is that same meniscus tear that's sutured in place. So that's what a meniscus repair looks like. It's near the periphery. Here's a more subtle tear on the undersurface on the third picture from the right, or from the left, I guess. And then on the far right, this is the part that's trimmed out. So we try to minimize how much we remove. And we probably repair the meniscus less than 5% of the time. So it gives you some perspective, because even if we want to do it, if we don't think it's going to heal, it's not worth putting the patient through a recovery that's often much more lengthy if we don't think there's a good chance this is going to work and we're going to have to go back and take it out. Next up, ACL. What is the ACL? It stands for anterior cruciate ligament, or cruciate means cross. So here's an example of an ACL on a left knee, and behind it is the PCL. You can see it's a little bit bigger. The ACL is important for controlling anterior translation or front to back movement of the knee, but also there's a rotatory component, which is critical, and that's really where it does its best work in a sense. ACLs are critical for cutting, pivoting sports like soccer, volleyball, basketball, football, anything with lateral movement. You kind of need an ACL in the majority of patients to be functional in that setting. While an injury can be contact in nature, where we'll see a lot in football where someone's blocking, they get hit from the side, kind of tear their ACL and MCL. Most of these injuries are non-contact injuries, meaning patients just kind of planned to cut and their knee gave out, or they landed from a jump. So what's the epidemiology? Some statistics at one point said 1 in 3,000 patients or individuals in society would tear their ACL. that projected out to over 100,000 reconstructions a year. And I imagine those numbers are probably higher in this day and age than they were at the time this data was collected. It's interestingly in women, 2 to 8 times higher incidence or frequency than in men. There's a couple of reasons for that. Hormones, the way the bony anatomy of the knee is constructed compared to their male counterparts, and also related to some muscle firing patterns or sequences of how hamstrings and quadriceps fire in athletes across genders. Certainly, we see more contact injuries in males in this subset of injuries as well as across knee injuries in general. So how do these people present? Again, I landed from a jump stop, my knee shifted, buckled, felt a pop. In many cases, I couldn't continue. I barely could walk, had to be helped off. Well, there's rare cases where people will continue with this injury and they can try to still participate to a brief extent. Many times there's fairly rapid swelling with an ACL. An injury that shows a swollen knee 2-3 hours later. This is it's an ACL until proven otherwise, compared to the meniscal tears are not like that at all. They have varying degrees of pain and stiffness as a result of the swelling. And then if you're dealing with a patient that's had this happen before, or maybe in a subacute setting where it's been weeks or something like that, they may tell you, hey, my knee keeps giving way, or I tried to go back and play and it did it again. Here's an MRI on the left of a normal ACL from the side, and then here's one on the right. You can kind of see the tear through the middle and the swelling that goes with it. Here's a left knee ACL and a PCL, and then on the right, kind of a shredded ACL when we get in there to deal with it surgically. So how do you make decisions about who to treat with surgery and who not? Typically, we term younger, which I put in air quotes, active patients involved in cutting, pivoting sports, or patients with active lifestyles, laborers. When I was a resident, if you were over 40, you were probably not getting surgery. Now that's evolved where we routinely do patients in their 50s and sometimes even 60s. So it really depends on their physiologic age and what they're doing from a recreational standpoint and or work-wise. We don't ever tell anyone you're too old. Certainly patients with recurrent giving way episodes, meaning sometimes patients will get hurt. They think, I don't really want to do surgery. And yet they find that their knee keeps giving out with relatively minor activities of daily living, as opposed to just they've cut out the sports and it's not enough. They're still having problems. Those patients get surgery in many cases. Patients that have big bucket handle meniscus tears that are repairable, we want to save the meniscus. And to do that, you have to have a stable knee. So you kind of have to treat them both together. Similarly, if you tear your PCL and your ACL together, or your MCL or LCL, these we term multiligamentous injuries tend to involve surgical treatment of both injuries. And some patients just want their knee fixed. So they may not need ACL surgery based on their age or activity level, but some people don't like the fact that they have a quote tear. And so we talk to them about that. And in some cases, they're willing to go forward with surgery because they want to be whole. And certainly that's not totally unreasonable. A relative contraindication is someone who has a lot of knee arthritis, meaning they're probably closer to knee replacement than they are having another surgery like an ACL surgery. And I guess the other contraindication is pain, in the sense that we have patients who have pain but have an MRI that shows they have a torn ACL. Well, the ACL is not really a pain generator, and it's not a pain relieving operation. So that's not a good reason to do an ACL. Whereas someone who's like, hey, my knee gives out, I can't walk down the stairs, or it buckles on me all the time, I don't trust it. That's a great indication to have your ACL reconstructed. So the surgical treatment typically involves a rebuilding of the ACL as opposed to a repair, although there's a subset of repairs that are being done with certain types of ACL injuries. Time will tell whether that proves to be a good choice. We treat any meniscus injuries, any smoothing of the articular cartilage, as well as any other ligamentous injuries at the same time. Those patients who opt into a non-surgical group, first thing we do is we counsel them about, hey, let's take away those dangerous activities. No cutting, pivoting sports, at least in the short term. We put them in some therapy to build up their quads, their whole core, to kind of strengthen their lower body to give them the best chance of success without an ACL. Certainly activities like tennis, which involve less cutting, but still some movement, are more doable than going back to play soccer and basketball, especially in the female athlete. And bracing can help. Their braces can help you in the workplace, help you transition back to sport in these patients, but there's certainly no perfect brace, right? So you can rehab and wear a brace and go back and boom, it can give out again. And sometimes we have to counsel athletes that who get hurt during like their senior year of football and they want to try to finish the year out. That can be attempted in certain cases, such as if you're a lineman. It's much more difficult if you're a running back or wide receiver or other skill position player. So here's what an ACL graft looks like: a left knee patellar tendon graft. There's your PCL. Here's a side view of that same graft, and it shows how it's secured once upon a time with metal screws. Now we use more biabsorbable screws. We also use what we call soft tissue grafts like hamstring tendons or donors of hamstring and other ankle tendons around the ankle. These can be kind of pulled up into a socket and secured with like a suspensory fixation. We call it button here. So here's an example of that here on the right, and we can secure the graft in the lower leg with a variety of means. Next up, MCL. So medial collateral ligament basically is on the inside of the knee, connects the tibia to the femur. Typically, it's a contact injury like the bottom right. Tom Brady found out years ago where he foot planted, he gets hit from the side and his knee bends in like it shouldn't. They often will feel pop, pain on the inside or medial aspect of their knee with or without some localized swelling or bruising. They don't tend to get the big swollen knee like the ACLs do because it's not in the joint. They typically get stiff though and lose range of motion. We grade these based on the degree of opening. Like Tom's is a grade 3. It's wide open, more than 12 or 10 to 15 millimeters, where there's lesser grades of instability that we sometimes will see and milder injuries that are less violent. Many times we get MRIs, although it's not an absolute for these injuries, because sometimes they can be diagnosed clinically without, they don't have swelling. Certainly the higher level of athlete you're dealing with, from high school to college to professional, the more likelihood they're getting an MRI. Most MCLs can be treated conservatively. They may or may not need crutches depending on their ability to weight bear without a limp. Bracing is done. Lower grade injuries may get a brace like this. Higher grade injuries may get a longer brace like we do post-operatively, almost like a cast to kind of protect the leg and allow some more healing before weight's taken across the knee. With icing, anti-inflammatories, compression dressing, all those things to help achieve some of those goals we talked about earlier. The majority of MCL sprains are kind of partial tears. They don't rip in half like an ACL. They tend to kind of tear in degrees. So all the grade 1s and 2s and most grade 3s are treated non-operatively, whereas once upon a time, these were often treated surgically years ago. Now, basically, if your knee is not unstable in extension, if you don't have other ligaments involved, or sometimes by MRI, it'll tell us if it's more of a tibial-sided injury. Why is that important? So the reason the MCL heals well is it's outside the knee. There's good blood supply, and that's why they can be treated with bracing in time. The tibial-sided injuries sometimes allow some of the knee joint fluid to get in there and avoid it from healing back or sealing. Similarly, that's why ACLs don't really heal, because the synovial fluid or the joint fluid that lubricates the knee has an inhibitory effect on healing. Patellar instability, sort of the kneecap kind of popping out or dislocating. It can pop all the way out and stay out, like I had happen once when I was in high school. Sometimes it can sublux where it slips out and then quickly jumps back in place. Typically, it's highest incidence in young active patients, 13 to 20 years of age. There seems to be a little higher recurrence rate if it happens to the younger individuals, between like 12 and 15. Teenage females may have the higher risk of that recurrence as well. And it often can look like an ACL tear because it'll pop out and back in. They get a huge amount of swelling, and so it can be confused with an ACL. So you have to kind of be careful that that's kind of weeded out during the evaluation process. There was a meta-analysis of 25 different natural history studies recently that showed that there's about a 31% redislocation rate. So if it happens once, there's about a third of the time it's going to happen again. And then it seems like patients who happen twice or more, 50% of those patients continue to have recurrent instability and maybe shift them into a different patient group. So the anatomy, the kneecap or the patella is a sesamoid bone. What does that mean? It's basically embedded within the patellar tendon and the below and the quad tendon. The bony restraints of the patellofemoral joint. So here's a shot with the knee bent. So the deeper that groove is, the more it helps stabilize the patella. And that typically happens beyond 30 degrees of knee bend all the way to full flexion. But But these injuries tend to happen with the knee straight to just early bending to like 30 degrees. And so the bones don't really contribute as much, and more of the stability comes from the soft tissues. The key soft tissue is called the medial patellofemoral ligament. It goes from the upper medial half of the kneecap to the femur. That's this MPFL. It basically sits on like underneath the bottom of the VMO, which is part of the quad, the vastus medialis obliquus. And so that tends to tear somewhere along this course with a dislocation, or at least get stretched. So the VMO, because it overlies that, is a critical component of rehab for these injuries and just kneecap problems in general. And lastly, the retinaculum are just tissues that are not depicted here that kind of insert on either side of the patella. So mechanism of injury, often an indirect trauma, foot down, knees nearly fully straight, a little twist, and it's almost like the lateral quadriceps or vastus lateralis overpowers the VMO and pulls that thing out. And certainly recurrences happen frequently with twisting activities like volleyball and basketball, especially in young women. There are a few injuries that occur with a direct blow where your kneecap just gets kind of pushed out of place, but that's much less common. So imaging, we talked about x-rays. These patients get x-rays. Here's an example, top left, where the kneecap is sitting out to the side, so it's dislocated. Here's one below. It's a little more subtle, where the kneecap we call is sublux. So it's not really sitting in the middle, but it's kind of hanging out to the side. That would tell you that all these inside or medial tissues are stretched, or if not torn, to allow the patella to kind of sit out to the side. Here's a right knee. So when the patella dislocates or jumps tracks, so to speak, the inner part of the patella hits this bone out here called the trochlea, and that's it's a characteristic bone bruise we see with these injuries. Here's also a right knee where you can see that patellofemoral ligament and patellar retinaculum are torn off the patella, and with this resulting huge effusion or amount of swelling in the knee. So patellar dislocations can be benign, where the kneecap jumps out and pops right back, and there's really no trauma to the cartilage. It can be minor, like cracking here on the top right. Bottom left, you can kind of get a flap of cartilage, and that's where things get to be problematic, where you can't just leave that. And even in a larger sense, you can get one like the bottom right, where you have cartilage and then there's some bone on the back. The difference is if you have a little bit of bone on there, a lot of times you can put that back and secure it with a variety of means to get that to heal. Whereas if it's just cartilage, it's pretty much has to come out and it's gone. So again, conservative management, the first thing you want to do is pop the patella back if it's not back in place, and then some kind of wrap or brace. If it's a frank dislocation like this gentleman experienced, we typically put him in a knee immobilizer after the first dislocation for 3 weeks. It's thought that holding him straight may allow for some healing of those medial tissues and lower some of the recurrence rate. If the knee's huge, we'll drain the knee and then use these other measures we've referenced about controlling pain and swelling. This is one time we're not going to move that knee right away. We may have them try to do some things to fire their quad. Now, if they dislocated, they're getting an immobilizer. They're probably getting crutches to kind of protect their weight bearing early on, help keep the swelling down. The less they swell, the easier things will kind of calm down and they'll feel less pain. So you give them some limited home exercises to kind of fire their quad and move their foot. And then when the brace comes off, or the immobilizer comes off, rather, we switch them to more of a patellar stabilizing brace, as demonstrated on the bottom right. It's kind of got like a horseshoe that holds the patella in place. So this is a left knee. So this strap kind of holds the patella medially and it keeps it from dislocating again laterally. That in conjunction with PT to work those quads, especially the VMO, are critical in progressing patients back to activity, to job or sport. And these can really be significant injuries where the return to sport on average might take anywhere from 6 to 12 weeks, depending on how much trauma the knee experience, how much the quad shuts down, how much swelling they have, etc. Surgical treatment typically involves an arthroscopy to kind of go inside the knee, clean up this cartilage debris in the bottom right, we call countermulation on the patella, take out any loose cartilage that is floating or even bone. Rare cases, we'll have to put some screws in that if there's enough of a bony injury as depicted in the bottom left. On occasion, we'll do a lateral release. So we talked about how these, in the top right photo, how these medial soft tissues are disrupted. Sometimes the lateral tissues over here called the lateral retinaculum can still be tight, even to the point where they're tilting the patella. Those can be released. Formerly, that was done as isolated treatment for this problem, but it didn't work. But sometimes you can do it in conjunction with doing some of these other measures. And the gold standard really has become what's called a patellofemoral ligament reconstruction, where you use a hamstring graft from the patient or a donor to kind of reconstruct the MPFL and kind of recenter that patella with or without that lateral release. And that's done really after 2 or more dislocations, and depending on the patient and their tolerance for this. In rare cases, you can repair the medial patellofemoral ligament after an isolated one-time injury, but most of the time you don't need to do that. Statistics would suggest that you can treat patients after a first-time dislocation conservatively, and they will do well. Distal realignment involves if there's any bony or angular deformities that contribute to this instability problem that involve cutting bone and kind of realigning the patellar tendon, but that's done less frequently. Back to that contusion, that generic term, a blow to the soft tissues in the front of the knee can make the bursa in the front of the kneecap swell up big, contuses the fat pad or even the articular cartilage underneath. And that's where sometimes we use an MRI to see, did they bruise the bone? That sometimes can lead to more swelling, more ache, and longer recovery. So these patients typically present with a diffuse achy pain and discomfort in their front of their knee. Typically they grab the front of their knee diffusely and say, hey, this is where it's hurting me. They may have swelling, stiffness, but also some popping, catching, grinding from that, if that cartilage on the back gets traumatized in particular. They may have pain just with walking or transitioning from a chair, climbing stairs, and certainly squatting, stooping, kneeling. Those kind of activities are all problematic. And so it can also be termed patellofemoral pain syndrome. That can occur traumatically, but sometimes this thing comes on insidiously with time, more of an overuse problem. Very common. We also term it anterior knee pain. They grab the front of their knee with or without the grinding. The grinding is that chondromalacia we see on the right. And this is really the most common knee condition we see in the office. It's kind of like our low back pain. Extremely common in adolescents, young adults, and women in particular, and it easily comprises a third or more of the knee pain or knee problems we see in the office. Here's again that kneecap, normal looking cartilage, not so normal looking cartilage. So how are these patients treated? These can be very challenging. First of all, we take away the inciting event. What if you're doing something that hurts? We want to cut that out if at all possible. So take away the pain generated. You don't want to push through pain. It's not a no pain, no gain thing anymore. Keeping weight down, that can be a factor in these patients. Training errors, which we're going to get into a little more. Taking away running on a pavement as opposed to riding a bike. Sometimes even subtle changes like, hey, I changed my shoes or I changed my orthotics and now I have pain. Physical therapy is the hallmark of treatment of this. It's therapy, therapy, therapy until proven otherwise. And that includes not only your quads, but like really core strengthening down, especially involving hips and the like, to really be protective of the patient's gait and overall alignment of the lower leg. And we try to shift them away. So if they're walking or running and the knee's not happy, we say, get in a pool, get on a bike, get on an elliptical. Those all tend to be low to no impact and are better tolerated. Sometimes even bracing like this. We don't want to immobilize the knee. We want to keep it moving, but sometimes we can kind of redirect the forces across the knee or how it's lined up in that groove to alleviate pain as well. So overuse injuries, just to finish, typically they're the strains, the bursitis, the tendinitises. They're often attributable to what we call training errors. So training errors of, hey, if I'm going to go from being a casual runner to say I'm going to run a marathon in the fall, but you want to do it in a graduated fashion. Training errors, typically they recommend you don't want to increase the frequency of your runs, the intensity of your runs, or the duration or distance, time, more than 10% per week. And those that exceed that, you're often kind of setting yourself up for failure. Certainly running surfaces, as we alluded to. So pavement is not very forgiving. When patients first start to go back to running after an injury or sometimes surgery, I've talked to them about, these treadmill, track, sometimes even trails that aren't necessarily hilly can be more forgiving than pavement. Poor conditioning in general. Someone who decides, hey, my New Year's resolution, I'm going to start running for exercise. If you haven't really built your muscles up, built up your quads and legs in general, once you get fatigued, the pain can set in. Similarly, if you don't stretch, poor flexibility can also load the patellofemoral joint in the front of the knee. We particularly see that in adolescents when they go through growth spurts where the bones grow faster than the muscles, and there's a lot of pulling on the front of the knee, whether it's the kneecap or above and below it. At the growth plates, when we see problems, such as when someone who decides, hey, I'm going to run track for the first time. They'll grow out of it, but they're at risk during that time where their body's changing. And then we talked about the shoe wear changes. So same thing, overuse treatments, we take away the inciting event, look back at how they're training, how we can make that better. Think about changing the surfaces, exercise activities, shoe wear, etc. And I guess in the interest of time, we're going to cut this off, and that way we can answer questions if you have any, and I appreciate your time.
Okay, we do have some questions, Dr. Comisar. First one is, can you see bone in an MRI?
Well, you can see, certainly see bones on x-rays like we showed, but MRIs, you can see the bone in a different way. It shows, we'll see what's called bone edema, or like swelling or inflammation, kind of like that bone bruise concept. We can see that in an MRI that we can't see in an x-ray. MRI can also actually show fractures, or like subtle fracture changes that don't show up on an x-ray. However, sometimes it's almost too sensitive, and it almost would like overcall bone injury, if that makes sense. So in general, when we treat injuries of the knee, we use MRI to look at tendons, ligaments, muscles, meniscal tissues, etc. The bone information is helpful, but if we're really worried about the bone in and of itself, we use CAT scans to complement x-ray, because CAT scans give you more specifically bone detail. Does that answer your question?
It does. Next question is, what's the worst knee injury in sports?
The worst knee injury in sports that I have had the unfortunate opportunity to treat is what we call knee dislocations. And that's when the femur and the tibia are totally separated. So it's not just your kneecap coming apart, it's the whole tibia and the lower leg shifting out, like we had, I'll show you one here. And the reason this can be so severe is typically involve not one ligament, but 2 to 4 ligaments. And, but you also have to worry about what else is injured. The arteries and nerves around the knee. So sometimes you can get, and this is a dislocation on the top right. So it's imperative to try to get that realigned or reduced as soon as possible. The artery, the main artery of the lower leg is behind the knee, and it can get tethered here. The nerves can get injured. You know, I've seen people dislocate their knee in a traumatic setting, because it's often high energy, meaning it can happen in football. I've seen it happen in football. It can happen in motorcycle, car accidents. So it's typically high energy. But yeah, I've had a guy that dislocated his knee, that had his nerve torn on the side of his leg, that, you know, he needed much further surgery down the road on his foot and ankle as well as his knee. Okay,
thank you. How do you determine which meniscal tears can be repaired?
Good question. I had a little picture. It's kind of like a pie graph where, imagine if the blood supply is coming in on the outside or the periphery, and so the blood supply is coming in out here, and they divide it into thirds. So the inner third is called the white zone, and that's felt to be avascular. And so those we trim out. Then the ones that are more kind of in the middle, it's kind of like in between the red and the white. The red's out here where the blood is, so they call it the red-white zone. And those, it's more of a judgment call depending on the quality of the meniscus, the age of the patient, because unfortunately that the adolescents and young adults have the best chance of healing those. And then lastly, the ones that are way out at the edge here, those are ones we consider repairing in virtually anybody. They tend to happen more in the younger patients, and as we get older, the meniscus tears tend to move more to the middle.
Okay, thank you. What is the unhappy triad injury?
Well, the unhappy or terrible triad is often, historically, was if you tore your ACL and your MCL and your medial meniscus. Truth be told, it doesn't happen that often. Most of the time, if you tear your MCL and your ACL, you're going to hurt your lateral meniscus as opposed to your medial meniscus, but that's kind of the unhappy triad or terrible triad that was kind of popularized years ago. And we still see it in some instances, but generally when you tear your MCL and the joint's separating, the meniscus is actually spared on the inside and it gets kind of banged together on the outside. But there are rare cases where you can kind of get them both, or get both medial structures at the same time.
Okay, perfect. Now we have a couple ACL questions, and we could probably roll it up into one. So,
Mhm.
can you play sports without an ACL? And then, how long is the recovery from an recovery rehab time on an ACL surgery?
It's statistically you can't play with without an ACL. However, there are instances where people have done it. In fact, there was a recent college wrestler, I think, who won the national championship at his weight class, who revealed after that he wrestled without ACLs. That's not normal. We have people what we call copers, and that's probably a small percentage of the population, 5 to 10% at best. Most people find they can't cope because they can't compensate, if you will, and that if they try to participate in these sports without an ACL, they tend to have their knee continue to give out. And why is that bad? Well, sometimes when the first time happens, the ACL tears alone and nothing else occurs. But often, the more your knee gives out, there's an increased incidence of tearing the meniscus, sometimes beating up the cartilage on the end of the joint. So the collateral damage, if you will, goes up. And that's why after a one-time injury, we tend to push surgery in the majority of patients, certainly anyone under 40 to 50 easily in this day and age. But there are those outliers. But the chances, do you want to roll the dice and take a chance on your knee or your patient's knee? Most of us don't want to. Now, in extreme cases, we'll have patients who get hurt maybe like their senior year, depending on their sport and their position. We rehab them, put them in a brace and say, good luck. Let's see if we can get by. That's the exception. The second question, I think, was about how long it takes to recover. Right now, I tell patients 6 to 8 months, 7 to 9 months, something in that range. And that depends on their age, what they're trying to go back to, what the rest of their knees like. Do they have any other injuries to the meniscus or other ligaments? I've gotten more conservative in my 20 years of practice. When I first started, it was great if you could get someone back before 6 months, or how fast can you get your patient back on the field? 4 months, 4.5 months. We've done that. The concerns are, it clearly shows that patients going back before 6 months have a much higher rate of re-injury. Most of the patients aren't ready muscularly. Everything may look good on the knee, but they haven't developed their strength back in their core, their hips, their quads and hamstrings to be protective. And so while it was great to send people back early, having re-injuries is devastating for you as a patient, for me as a physician. That's a huge loss. I take that personally. And so we try to be smarter about who we let go back and when. And so now, instead of like saying, hey, everyone can go at 6 months. Some people are ready at 6 months. Some people are ready at 7 months. Some people are ready at 8 months. Some people take longer. How do we decide? There's strength tests or performance tests we do to kind of simulate activities in our clinic and other physical therapy clinics to kind of test you against the good leg, against national baselines, and see, like, are you as ready as you think you are? We try to tease out if there's any subtle weaknesses or discrepancies that maybe make you feel better than you really are, in a sense. And we want to lower your injury risk. That's really my main goal. So if I make somebody wait a little longer to go back and play, it's strictly in their best interest, because I want them to succeed. I don't want to have to come back and see me again, because that's a success, and the re-injury rates can only be driven so low, and they're devastating. The rates are really highest re-injury rates in female basketball and soccer players.
Along those lines, can an ACL become stronger after surgery?
It's not so much that it's stronger, but the graft matures. So we think certainly letting that graft kind of heal in, we think there's a period of time where it actually gets weaker before it gets stronger. So certainly once you get past 4 months, then beyond that, I'm not sure if it gets stronger, but maybe it should be healed on either end of the bone by then. The inner part goes through a ligamentization process, and it probably varies in every patient. But the bigger part of getting stronger is really more everything around it. We talked about those quads and all those other things that we think are protective of your ACL. And that's what we really focus on during months like, 3 to 6 or 8 after surgery.
Okay, thank you. As an active person, is there anything I can do to avoid these types of injuries?
Well, like things like arthritis are going to happen to a certain extent to anybody just because of genetics or activity, sometimes old injury or weight or choice of activity. I mean, with ACL injuries, some of that depends on what things you choose to participate in. There's a certain inherent risk of certain types of sports. There are ACL prevention programs that are being designed. There's a wide experience in Europe where, in soccer players, what's called the FIFA 2011 campaign, where they basically design drills for teams to go through, young women and men, that have shown to be protective. The hard part is implementing it in this country, is to find the time that the coaches to devote the time to it, and who's going to pay for it, because that's at a premium. And I guess in general, it's like for females in particular, we try to teach people to land with a little bend in their knee instead of stiff-legged. That's one way to avoid an ACL. Kind of round off your cuts instead of a sharp like jump, stop, and cut. That's another thing. But there's a lot of factors. Some of it just is the risk of participation in a sense. Meniscal tears kind of happen. There's really no good way to prevent those. If they're going to happen, they're going to happen. MCL is a contact injury, so if you avoid those kind of situations, that's much less likely to happen to you, certainly. But overuse, those things happen if you just kind of make quick adjustments in your training. Either go from 0 to 60, not doing appropriate stretching and kind of strengthening on the side before you dive into an activity. Unfortunately, a lot of us are guilty. I have a New Year's resolution. Someone in their 40s or 50s decided, hey, I'm going to turn over a new leaf and start working out every day. And sometimes that could be a little too much, and the body's going to say, hey, time out. And those are necessarily not injuries, but more just like pain you can get. Did I answer the question?
Are the meniscus, so based on that, so the meniscus tears are more common than the ACL tears?
Yeah, they can happen. And say about half the time you feel something when you did it, you've squatted down, you twisted and you felt it, but sometimes your knee just starts hurting. And so it's not always clear why it happened. Yeah, they are more common. Sometimes they occur in conjunction with arthritis, and then we have to kind of tease out which we think is the bigger culprit or most responsible for the symptoms. But yeah, the meniscal tears are a little more common.
Okay, and then one last question here. Does KT tape work for knee injuries?
KT tape can help a lot. Couple roles. One is after surgery. A lot of times your muscles are weak, your quad's not really it kind of steers your kneecap. Imagine that groove. And the KT tape can kind of help realign it into a more favorable position where sometimes someone's getting pain with certain knee exercises. So I'm a big proponent of what I call patellar taping or KT taping. Beyond that, back to sports, some patients like that as an alternative to wearing like one of those patellar braces, something that's more bulky. The tape or the KT tape gives them enough support and kind of correction across the knee that they don't need something bigger. So it definitely has a role. I mean, it can only do so much, but it definitely has some good applications for our patients.
Great. Thank you, Dr. Comisar. Is there anything that you'd like to wrap up with?
I don't think so. I just thank everybody for their time, and we're hoping everybody's going to be able to get back and get out there and participate in the sports that maybe have been a little bit muted over the last year.
Okay, thank you so much for your time this evening. Everyone, thank you for participating in tonight's webinar. Our next webinar will be on May 5th at 7 p.m. Dr. Scott Stevens, orthopedic shoulder surgeon, will be speaking. Look on our social media pages for additional information on that specific webinar. Thank you again for your time. Have a great rest of your evening.
Thank you. Well, hopefully we didn't put them to sleep, huh?
No, it was good. I mean, everybody knows about knee injuries.
Yeah, I mean, a lot of this stuff is, well,